So can I just make sure that you can hear and see us okay? If you could just put something in the chat box for me. Perfect. Thank you ever so much.
Wow.
Yeah. That's quite good. At least it's working.
Yeah.
Okay. So Diane, can I hand over to you for you to introduce Mike? The rest of the guests, can I ask that you put your turn your cameras and your mics off?
Thank you, Sharon. So I have the pleasure of introducing Professor Mike Lewis. So Mike Lewis is Professor of Oral Medicine at Cardiff University. He served as Dean of the School of Dentistry at Cardiff University from 2010 to 2017. He is also past Dean of the Dental Faculty of the Royal College of Physicians and Surgeons of Glasgow and Director of the Clinical Board for Dentistry at Cardiff and Vale University Health Board. Professor Lewis has published over 200 scientific articles and co-authored 6 medical textbooks. He has delivered more than 600 postgraduate lectures worldwide, and in addition, he has been president of the British Society of Oral Medicine and the president of the British Society of Oral and Dental Research. He's a very busy man. Thank you so much for presenting for us tonight, Mike, and it's all over to you.
Excellent. Thank you, Diane. I always like talking to your audience. It's my favorite. And we're on a different subject today. Usually is mouth cancer and oral medicine, but we're focusing on the essentials of COVID-19 and keeping us all safe. Well, there we are. Just in case you're missing the practice today, this is the there's a bit of gingival abnormality going on there with this chap. That he was actually referred to me as an urgent suspected cancer, but it wasn't. It's just that he wasn't actually cleaning his teeth. And the microbiology of the mouth, as you all well know, is very complex. And plaque, when you look at it under a scanning electron microscope, an SEM, and that's a picture from one of the oral microbiology books, shows a complex nature of the different microorganisms present. Well, within the oral microbiome, which is the old term, the oral flora inside your mouth, there are bacteria, protozoa, but there are viruses. And the viruses that have come along to dentistry over the last 50, 60 years, there's hepatitis viruses and the implication that herpes viruses, HIV, but of course, the one that's the new game changer that's come along is our dear friend coronavirus. So how many of us 18 months ago had never heard of coronavirus, but everyone in the world's heard about it now. So the response by dentistry and medicine, in a way, to hepatitis B, hep C, HIV, and herpes viruses was the development of the autoclave. And these organisms were destroyed by the autoclave, and we could deliver dental health care safely. Then some of you will remember when prions came along, and prions cannot be destroyed in an autoclave. And that's when it was understood that you had to wash instruments, to wash the prions off, because they would survive the autoclave. And that's when practices then had washer disinfectors and the importance of cleaning or disinfecting or decontaminating the instruments before they went in the autoclave. Right, well, that's how we responded to those viruses and the prion proteins. This is the new game changer, coronaviruses, and that's little schematic of the coronavirus there. I'm sure you see it all on the telly and in papers. When 2019, there was 2019 new COVID was first described in Wuhan in China. So late 2019 was when the virus was first identified. It was soon renamed to SARS-CoV-2. So that it's got its new little name there, probably the first time you heard about it. Now, to teach virology, when I'm teaching virology to people, undergraduates or postgraduates, it's very simple. There's only two things you need to know about a virus. That's the coating and what's inside, the egg. So when I was doing this to an audience of European journalists in Paris, I asked the organizers, make sure they've all got a Scotch egg. So I hope none of you have had Scotch egg for tea tonight. But when you chop a Scotch egg in half, you can have a look and see what happens. Now, the crumbly coating on the outside That is critical with a virus because that will determine which cells the virus can get into. A virus is an obligate intracellular parasite, which sounds a little bit like an insult, but it means it has to live inside a cell to go about its business. And spike protein is one that we will have heard about here. I'm just going to minimize something on my screen here, sorry. Right, the spike protein, you will have heard about that because there's been lots of attention to that. And it gets its name, corona, from the Latin for crown. Corona from the Latin for crown. So that's how coronaviruses were called, because of that, the appearance. Now we've chopped the Scotch egg in half here, and inside a virus is either DNA or RNA. And our dear friend SARS-CoV-2 is an RNA virus. As I say, the important thing about the structure of a virus is the membrane, the glycoprotein that's on the surface, the crumbly coat of the Scotch egg, because that will determine which cells it can infect. It's also the target for vaccine production, as some of you will well know. And going back historically, when hepatitis B vaccines were developed, in fact, they were developed, the Australia antigen, which some of the more mature people in the audience tonight might remember, but that's actually, you were inoculated with a bit of the surface protein, the hepatitis B surface antigen. Now this schematic here, we've got the little virus on the left-hand side, and it comes bouncing along and it comes up against a cell. Now, as I say, the virus has got to get in that cell to go about its business. So what will happen is it has to bind in to the, and in the coronavirus, it binds actually to cells in your lung. More about that in a moment. But once the virus gets inside the cell, it goes about what a virus does. It becomes a dictator, and it tells that cell, whatever it is, stop being a happy little lung cell or a happy little epithelial cell, make more of me. So the virus starts replicating in these various stages, to the fact that the cell dies, and then the virus spreads to the next cell and the next cell. But it causes, of course, that cell death causes an inflammatory reaction, and we'll come back to that in a minute. So basic virology, disruption of the surface glycoprotein, and this is why I put this in bold, makes the virus non-infectious. It cannot get in the cell. And the great thing is that the vast majority of viruses, that crumbly coating on the surface, is very susceptible to soap, alcohol, and that is the basis of our wash your hands. Mouthwash, and I'm going to mention a little bit about that as well, because mouthwash disrupts the surface protein and therefore makes it inactive. And I'll talk a little bit about that, the pre-procedural mouth rinse, when we get onto more about the practicalities of delivering safe dentistry in the COVID era. Toothpastes, interestingly enough, contain either stannous fluoride, amine fluoride, or zinc, and then these have been shown to be highly effective, 99.9% at neutralizing COVID-19. And it does that, once again, by disrupting the viral envelope. So anything that destroys that crumbly coating on the Scotch egg will deactivate the virus. You might say, oh, well, hold on then, well, let's all brush our teeth. It cannot prevent infection and all the things that we're doing with the mouth rinsing and anything else and the toothpaste. It will not prevent infection, but it is likely to reduce transmission, which is obviously what we've been trying to do over the last year or so. So where do the coronaviruses, what are they? You may have heard them here, the zoonotic viruses that can transmit from animals to humans. And the one that I first came across and was aware of in relation to dentistry was SARS, the severe acute respiratory syndrome, SARS in 2002. What's that, some 20 years ago? And coronavirus in that one, the SARS-CoV came from a cat and transmitted into humans, then started infecting humans. There was MERS in 2012, which some of you might not have heard of, but Middle Eastern respiratory syndrome, because it was contained, came from a camel. It was transmitted from a camel to humans and then started infecting humans. COVID-19, of course, there is some debate about this, that you hear a lot about a bat, with living with bats, and the poor little pangolin has probably been getting more attention that it deserved. But there is this idea that it's in close proximity to humans, that these viruses can jump from animals into humans and then spread within humans. Live markets. I'll show him when I've given talks before, I've shown more graphic images of live markets. It's quite horrible. This is me some 15 odd years ago when my hair was a little less gray, or platinum as I call it, in China with a live market where I could go and buy myself a little chicken and do something with it. But they're just horrible, absolutely horrible. And this is where cross proximity of humans with animals, this is where it comes from. So COVID-19 is the condition, not the virus. We know the virus is SARS-CoV-2. COVID-19 is a viral pneumonia, like a respiratory in a disease. And the virus here, the little SARS-CoV-2, the crumbly coating wants to bind to alveolar cells, pneumocytes in your lung. So that's why it infects the lung and respiratory. And it then replicates, as I've shown you. So it replicates in those cells, causes the cell death, and then there's a huge inflammatory response. And you might have heard about the cytokine cascade, where there's this huge inflammatory response to the lung damage. And therefore you get fluid buildup, like you would in any inflammation in the tissues. Remember, the fluid comes in. So it builds up in the lungs, and then people have severe difficulty in breathing. So that will then, if you can't breathe, you can't get the oxygen into your bloodstream, and that's when it becomes life-threatening. The interesting thing, though, is most people who have died from COVID-19 don't die from the fact they can't breathe, but it's actually the effect on the coagulation. Because of this inflammatory response, the clotting system in your blood goes a bit astray, and you get microthrombi, little blood clots, and they clog up your organs, and so you get organ failure, and that's sadly what kills a lot of people. But as we know, there's a wide variation in response to the virus. I had antibody testing back in the summer, and I was positive, but I can't actually remember being ill. I had what I thought might have been a cold at the end of February, beginning of March last year, but I suspect that was me meeting the virus for the first time. But it can go from people having no response whatsoever, no symptoms at all, to the loss of taste, to eventually to the severe symptoms and sadly death, obviously. So how does this terrible virus transmit? Well, it's direct, it's like most viruses, direct contact with an infected person. And this is why we've all been staying 2 meters from each other. There's indirect contact, and that may be with surfaces in the environment. So we're thinking a little bit into the second part of my talk about surfaces within the dental surgery. Objects used on an infected person. And of particular and specific interest to dentistry, of course, is this airborne transmission and the aerosols. And although some people disputed it to start with, I was on the telly early on saying that it could be transmitted directly and indirectly, obviously through saliva. It's in saliva. So that's a little bit of background to the virus we're dealing with. Meanwhile, back in the surgery, this is me having a little lie down to have my little polish, but that was taken about 18 months ago, that picture, but I'm having to relax. It's the time I get to relax. Aerosols. And there are 2 terms you'll come across: aerosol generating procedures, AGP, and then the Faculty of Dentistry in London coined this term aerosol generated exposure, and AGE. They're essentially the same thing. It's creating an aerosol, and that aerosol flings particles, droplets, microparticles into the atmosphere. And of course, viruses are very small, and viruses can be within these droplets. And that picture they're demonstrating off a handpiece with the potential spray there, which I've backlit in that photograph I produced. And the instruments here are ones you guys will be using on a daily basis. The ultrasonic scaler, high-speed handpiece. Interestingly, air polishers. There is some research I've been made aware of that shows air polishers, in fact, are the worst of these instruments. And the 3-in-1 syringe, when you've got air and water, you can have air on its own, water on its own, but if you spray it both, that's not advised. And there's been so much talk about the aerosol dilution and settle time, the ADS, the ADS time, and referred in general discussion often as the fallow time, the time you have to let exist in the environment within the surgery for the potential risk of aerosolized virus being transmitted to somebody else who's coming into that environment. So here, this is me having another lie down, but more recently, this was just 2 weeks ago here, where unfortunately I had to have a composite inlay fractured and I had to have it repaired, but I took the advantage to take some pictures while I was doing this because we were under the full regular aerosol generating procedure here by one of my colleagues, and essentially one of the nurses helping him here during, you can see, it is absolutely essential. If I say this once, I'll say it 10 times today. These procedures, nobody should be working on their own or expected to manage the aerosol their own. Four-handed dentistry, full stop, there is no alternative. And there we are, that's a picture of an aerosol coming off this handpiece here. And let's have a little with it go. Oh, there we are, just in case you see here the potential of the aerosol that comes off off a high-speed handpiece. Now this is a spot the difference competition, because here we're going to run this one, and what you can see here, she's just moving out of the way, but in fact the high-speed, high-volume aspiration there is being applied, and that will remove 95% of the aerosol there is sucked straight up that high-volume aspiration. And that just shows you dramatically and visually how important there is. That this is spot the difference competition, demonstrating on the left how the potential, if you've got the drill in the wrong direction, what's going to be sprayed into the atmosphere. But there we are. There's the orange high volume aspirator, and it's gone. It's now being held by the dental nurse who's aspirating it and taking that. And that's just visually just shows you the importance of high volume aspiration. Dramatic. So high volume aspiration, greater than 8mm bore tube, and it will take, as I say, the vast majority, the 95% upwards of the aerosol goes scooshing up the aspirator. And there it is again. I will be your campaigner. I will lead marches. Four-handed dentistry is essential. It's the only way it can be done. So in that aerosol, there's and this is important to what Julie will be talking about later on in this webinar. Particles can be categorized as droplets or splatter or aerosol, and it's based on their size. And it's obviously the bigger the droplet, the bigger the particle, the gravity is going to pull it down more quickly. So things that are greater than 10 mu, influenced by gravity, will settle on surfaces and depending on their exact size and mass. And the majority of particles in aerosol are the large particles, and they will settle within seconds. The smaller ones, however, may take up to 10 minutes to settle, but we'll come back to the smaller ones later on. But the majority of particles settle quite quickly. And due to the particle size and trajectory, these larger particles usually settle within 1 meter of the source. Okay, so big particles drop quickly and don't travel very far. Small particles, that's true aerosol. So if it's an instrument you're using, and again, Julie will come back to this later on, if there's a true aerosol, then there's the potential for putting the virus into the environment. And they may, strange enough, may remain airborne indefinitely, but they can come within sort of 10, 15, 20 minutes. They might take much longer to settle, these very small particles. And because they're in the air a lot longer in the surgery environment, they can obviously travel longer distances. Now this schematic here just shows some aerosol, a mixture of splatter and a mixture of true aerosol, small sized. And that diagram just shows you that the bigger stuff's going to drop in the immediate environment, the controlled environment in the surgery. And 1% might escape that. And the vast majority of the bigger ones, 99%, are within 1 meter. So the aerosol time and clearance time is, I'm just going to move that there. That's fine. Is the time for larger droplets to settle by gravity and aerosol particles to reduce to a level at which it is safe to remove your respirator. And haven't we all had fun wearing these masks over the last 8 months? This is the actual, this is in the main clinic, well, one of the main clinics in Cardiff Dental Hospital and School. In fact, that very surgery is there is where I shot those videos when I was having my composite inlay repaired. And in this environment, it's slightly different to an individual surgery. Obviously, we're in bigger environments, but that no entry sign means nobody can go into that period of time and into that surgery until the appropriate fallow time that has passed. So we can then spin it round. Once it's ready again at the end of the session, you can put the tick on. So they develop these little no entry and go signs, and I'll just show those for obviously that's not in relation to an actual treatment session because there aren't any people in it, but I just show you that that's the signs that can be used. You just spin it around. So ventilation considerations, and that has every single surgery, every single dental hospital goes in a way has different ventilation. But the critical thing is the calculation of air changes per hour, ACH, the air change per hour. And this is what people, not me, but colleagues of mine are spending a lot of time calculating the air changes per hour and the period of air change or the volume of air change that's required depending on the procedure. Now, I don't expect you to read the sign on the right-hand side of the screen there. You can get it from the sdset.org guidance, but I use it just to show that they have developed a flow chart which takes you from the procedure, and then dependent on the procedure, what it is, it's a group A procedure that's like to produce an aerosol. The air changes per hour that you have in the environment, 1 to 5, 6 to 9, or greater than 10. Greater than 10 is what we're all looking for. So the air change you can achieve in the surgery you're working in. The use of high volume aspiration, everyone, if you generate, as I've already shown you in those 2 little videos, the impact of aerosol, of high volume aspiration. Use of rubber dam, that's a great one for, that will reduce the risk obviously of splatter and everything from saliva. And the length of the time of the procedure, whether the actual procedure when the aerosol generating equipment or pliant or handpiece or ultrasonic scaler is being used for less or greater than 5 minutes. And then you can calculate the so-called ADS or fallow time. There is a free calculator there which you can register on and calculate depending on the size of your surgery and the equipment you've got in the surgery. Okay, well, this was a paper I wrote, oh God, when did I write it? Oh, 11 years ago. And never thinking I would ever hear this paper again. I did it as a student project and thinking, well, this was in response to SARS, the SARS outbreak, particularly in Hong Kong, because one of my good friends was in charge of the dental school in Hong Kong at the time with the SARS outbreak. And then there was also at that time an increased incidence of tuberculosis, and tuberculosis is increasing in the world now as well, particularly in the UK. Legionnaire's disease. And I was thinking, well, could we have some sort of air cleaning system? Now, there were available, and this air cleaning system here, this big like a bit of space equipment there, this was the one that we were using 11 years ago. And we showed that, in fact, these bits of kit can significantly reduce or collect the small percentage of aerosol that's left in the environment. So the principle of air cleaning in the dental environment was established. And strange enough, that paper that we wrote 11 years ago now is being quoted quite a bit by manufacturers of various air cleaning systems. This is a one that is particularly good. It has a HEPA filter in it, which filters out very, very small particles. It's the sort of a grade of HEPA filter that's used in chemical warfare by, for the Americans developed. The filter size is 3 micron or smaller. So your SARS-CoV-2 will not get through that filter. There's a carbon filter there that removes organic compounds. These air cleaning systems were developed initially to remove the smell or just clean the air within a dental surgery. But they have the added advantage of UVC radiation, which zaps the viruses, bacteria, and any other fungi that happen to be going through them. And they're very clever. They react to, they're sensing the environment all the time. When they pick up little small particles, they increase the airflow through the machine. And they don't make a lot of noise. These bits of machinery will develop 20 air changes per hour. And you can put them in the clinic, in the waiting area, in reception, have them within the surgery. There's one on the left-hand side. There's my favorite hygienist, but she's at home today, hopefully, looking after her dad. Okay, PPE, that's another little 3 letters that we've got to be very familiar with, the PPE. And there we are, just put that in for you. Never one hanging around the neck, but you still see it. And of course, you still see it with the people. Now we're all wearing masks wherever, when we go into shops and all around, and you see people wearing them around their neck and around their chin and on the top of their head, extra. But it's procedure mask, a surgical mask, and the pre-PE for a procedural mask, ear loops, no seal at the side. I'm modeling this here before my haircut. There's no seal at the side. And also I find it mists up my glasses. They're disposable. They can be used, but we don't recommend them when we're treating patients in Cardiff and Vale. What hopefully the next slide will show you is a surgical tie mask. I feel that these have the little bit of metal gets to your nose a bit better, and the ties have a better seal around the side. But all sorts of, there's a load of videos out there, aren't there, of how people have adapted, how you put them around your ears and twists and all sorts of origami going on there. But as long as they're fluid resistant surgical mask and they're disposable, and that is acceptable. When I'm doing biopsies for mucosal biopsies for cancer patients, things like that, that's me just sat there like that. And acceptable with a visor for non-AGP. And in the first shutdown in March, our oral medicine clinics closed, and I spent a very enjoyable 5 or 6 months doing the emergency dental service. We were running it 7 days a week. And it was an eye-opener to me, because I have never seen so much dental decay. Well, since the days when I was doing the abscess studies in Scotland, a number of people presenting with advanced disease and abscesses. It took me way back. It took me back 35 odd years. But we ran the service and the patients were very grateful. But it really was an eye-opener of some of for me, for the dental disease that's out in the domain. Here's one of my SHOs kindly filtered with a FFP, modeling the elastomeric respirator. She hasn't got a visor on foot, because I just wanted to show the aspirator, obviously, when would have a visor on as well. So thanks to Rachel. And the types of these filtering FACEPIECE respirators, the FFP, are dependent on the total inward leakage, the till time. So FFP1, not greater than 20%, FFP2, 8%. And of course, the FFP3, which is the generally recognized one, is not greater than 2%. So it's the most effective FFP mask. We happen to use, there are many out there, but the Dental Hospital and School decided to use the 3M mask. It's a half face mask. This was decided by the infection control team and Dr. Wilson, who's a dentist, but also a microbiologist. The particular filter was chosen there, and the filters are changed monthly. They write on the filters on the side, and we change them monthly. And obviously fit testing is required, and I'm sure the vast majority of you have undergone fit testing. Hand hygiene, I'm almost coming around now for my 35 minutes. Hand hygiene, the most single important aspect of infection prevention. And I just can't go past one of these things nowadays without having a little squirt and wiping my hands. They're absolutely everywhere. And you now know why you're doing it. If you didn't before, I'm sure you did. It's just you're disrupting the crumbly coating of the Scotch egg. You're disrupting the coating of the virus so it isn't transmissible. And happy birthday to you, happy birthday to me, happy birthday. We sing it twice, 20 seconds when we're washing our hands, to make sure we wash our hands properly and in between our fingers, etc. The pre-procedural mouthwash, I said I'd come back to this because to start with, I was a bit of a fan of I thought this is a good idea. But I've hence subsequently been persuaded perhaps it's not that. It's not going to do any harm. Disruption of the viral envelope or hydrogen peroxide, povidone iodine, essential oils, a whole range of different mouthwashes will disrupt any virus envelope that's present in the mouth. The problem is, though, any impact is short-lived, because if you're getting respiratory secretion back into the mouth, then for a minute or two you might be all right, but then it's going to come back in again. So nothing against it, makes good sense, but there's no evidence that it has to be an essential part of the procedures. So new normal PPE, that picture of me is there when I'm doing the emergency dental service, fluid repellent apron, gloves, and here we weren't doing any aerosol generating procedures in this clinic. We were just seeing people presenting with pain, abscesses, dry sockets, pericoronitis, you name it. But fluid resistant surgical mask with eye protection. I like the visor. So I can still got my glasses. Whoops. Now, the PPE here, if you are doing an aerosol generating procedure, or aerosol generating exposure, fluid repellent gown, FFP3 respirator, visor, gloves, you're going to have to make a decision. We, on our expert advice of Dr. Melanie Wilson, consultant microbiologist, we don't have hair nets and we don't have shoe coverings. But I guess in your individual practice, you can make that decision. New normal. Well, I could do a talk again on all aspects of this, but I've only got 3 minutes left of my 35. But you're going to have to consider patient risk assessment, clinical clothing, uniform, footwear, hand hygiene, fit testing, donning and doffing your PPE, decontaminating your impressions, your appliances, waste disposal, ventilating, and your ACH calculations as well. These are two very good documents, but I label them as live documents because things on a daily basis, our understanding of the virus and our understanding of what we need to do to prevent its spread changes. So there's the one for the Scottish Dental Clinical Effectiveness Programme. They produce, they're a fantastic organisation that produce a lot of good guidance in all aspects of dentistry, in fact. And then the College of Dentistry and FGDP produced a document there as well. And you can go in online and look at either of those documents and get the latest. As I said, the print, they're live documents and they're being updated all the time. Vaccines. Well, here we go. Genetic sequence. The genetic sequence of SARS-CoV-2 was published in January 2020. So a year ago, we actually knew the genetic structure of this virus. And it might surprise you, because it surprises me, because I did a webinar about 2 or 3 months ago with a lady from America who's developing vaccines. And she at that time told me there was like 150, 116 vaccines in development. But my latest source of information tells me there's 233 vaccines in development. 61 of those got to the stage of clinical appraisal. The aim of a vaccine is to stimulate your immune system, to develop antibody. And basically, the ones that we've got at the moment are antibody to the spike protein, that's the crumbly coating of the Scotch egg. Please remember, no vaccine is going to be 100% effective. I'm amazed at the fact that the ones that have been developed are hitting 90% and greater. It's absolutely astounding, actually. Well, here's me between Christmas and New Year, thinking, what will I do today? I'll pop down to the local gym, sports hall, and get a vaccine. The Pfizer biotech one is what I had. Moderna's now becoming available as well. They're based on messenger RNA-based technologies. Adenovirus vector is the AstraZeneca Oxford virus. Varying adverse effects, including fatigue. I actually, talking to folks, I was sort of hot that night, and I don't mean sort of hot feverish. I just felt hot, and then I was all right the next day. Heather, to tell me my wife, she was flattened for about 48 hours, in fact. And my 95-year-old mother has actually had quite a severe reaction to it, and hence I'm up looking after her at the moment. So there are varying degrees of adverse events, which would you'd expect, but the vast majority of people, just please get it done. And I'm sure those of you working clinically have had at least the first vaccine. I'm not panicking about because I had the Pfizer, that I want my second one within 3 or 4 weeks, because I'm well past that now. I would rather other people have at least one shot rather than some of us having 2 and some people having none. I'm quite happy to have my next shot within the 10 or 12 weeks, which was coming up soon, but please get vaccinated. Okay, bang on 35 minutes. Please practice safe dentistry. Don't have to tell you that. That's the Dental Hospital School in Cardiff in the background with a nice sunny day. Promote a team culture. That is a pastiche on the thank you. There was made up of faces of all the staff as a thank you to the NHS, and you can buy T-shirts and things with that on. I think the important thing to get out there is the dental surgery is a safe environment. Dentistry, we've been dealing with hepatitis, herpes, prions, and we can deal with COVID. We can deal with the SARS-CoV-2 virus. It's a safe environment. We have the technology, and I just hope that's been helpful. And that's me bang on 35. So I'm going to press the next button now, and I suspect I stop sharing, and somebody will tell me if that's the right thing for me to do.
Yep, it was Mike. Thanks ever so much. Miranda and Filippo, could you put your cameras and sound on, please? Hi, Miranda.
Hello there.
Hi, Filippo. If I could just confirm to the audience, we can't hear you and we can't see you. You're all muted. All your cameras are off and all your sounds off. So you can sit there in your pajamas. We can't see you whatsoever. I'm going to hand over now to Miranda to introduce our next guest.
Okay, thank you very much, Sharon, and thank you, Mike, for your fantastic presentation to open us up this evening. So to introduce our next speaker for you tonight, Professor Filippo Graziani is full professor of periodontology at the University of Pisa in Italy. He is responsible for the subunit of periodontology, halitosis, and periodontal medicine at the University Hospital of Pisa. At the present time, he is also the visiting professor in periodontology at UCL in London at the Eastman Institute and honorary professor at the Faculty of Dentistry in Hong Kong. His clinical activities are fully dedicated to periodontology, and he runs his private practice limited to the practice of periodontology. So without further ado, please join me in wishing buonasera and welcome to Professor Filippo Graziani.
Good evening. I don't know whether you can hear me or not, and I will need the permission from the organizer to share my screen, apparently.
Yeah, I think you could just be, you should just be able to share that now, Filippo.
Yeah, thank you.
There we go.
Thank you. So my role today is actually to talk to you about periodontal instrumentation in terms of treatment of periodontitis in this specific era. And as it was said, I'm professor at the University of Pisa. Pisa being the most beautiful town in Tuscany. And as you know, Tuscany, there is another town that is called Florence, but that is an ugly one. So we're not going to comment on this specifically. And what I would like instead to focus is to talk a little bit about periodontal instrumentation, to highlight the treatment recommendation in terms of periodontal non-surgical treatments from the European Federation of Perio, focus a little bit on COVID-19 and the issue of oral health, and then how should we instrument nowadays, and maybe to draw some possible conclusion together. So you'd see these beautiful mouths in these pictures. These are all the periodontitis stage 3 and 4 cases. And you know, the periodontitis affects approximately the 50% of the adult population. Subjects with perio actually have problems because if it is untreated, tooth loss is going to occur. Numerous systemic diseases and conditions are associated, and these subjects should also an inferior quality of life. Actually, the European Federation of Perio in recent years had developed very effective systems of consensus conference that really underline and constituted the basis of the majority of the treatment that we have nowadays. We met in 2013 to discuss about perimedicine, 2015 to discuss about prevention of gingival inflammation. In 2017, you know that we had the meeting on the new classification. In 2019, finally, the meeting that is the base for the guidelines and recommendation of treatment from the European Federation of Perio. And this is actually the meeting that allowed to highlight some important factors. So in order to pass and to move from this stage to this one, where actually we have the same condition, but yet under control, we need to understand the disease. To have periodontitis, you need to have bacteria, first of all, but bacteria per se are not enough because we all see patients that never brush their teeth, but actually, in fact, they haven't lost a single millimeter of attachment. In fact, you need a tendency to make inflammation. So if a subject is prone to over-inflammate, then will actually develop the attachment loss, which is the clinical sequela of periodontitis. So if the disease is caused by bacterial inflammation, you would understand that the treatment of the disease would rely on something that you do towards the bacterial component and something that you do towards the susceptibility. In terms of bacterial, well, you can actually teach the patient to brush effectively, and this is supragingival self-decontamination. You might want to remove plaque accumulating factors, i.e. calculus or overhangs, but you also need to rely on subgingival instrumentation, and sometimes you might consider to provide also some sort of adjunctive treatment. So this is what we do in perio when we focus on bacteria. So what do we do instead of inflammation and the susceptibility? Well, most importantly, we work on habit management, such as smoking. We need to check the metabolic status, the type of drugs, and most importantly, nowadays, it's getting more and more relevant, the fact that being a periodontist, doing periodontology, being a dental hygienist, also mean to provide coaching for a proper lifestyle. So stress, nutrition, and physical activity are very much part of, I think, of our ethos. So these 8 aspects are really the core of periodontal treatment. And I would like to focus mainly on subgingival instrumentation, of course, for the time that we are given. So subgingival instrumentation is basically all the procedures that we do to remove the things that can create disease on the root surface. And there are mainly 3 types of instrumentation that I would like to highlight. These are debridement, scaling, and root planing. Please bear in mind that one is actually more morbid than the other. Namely, when you are doing scaling, you are also doing debridement because scaling is more invasive than debridement. So when you're doing root planing, you are de facto doing also scaling and debridement, being root planing more invasive than scaling and debridement. And what are these 3 types of treatment? Well, basically, debridement is just the removal of the plaque on the root surface. So it's like the equivalent of coronal polishing. Scaling is the removal of all the calcified concretions, so calculus, on the root surface. And root planing is the removal of the pathological cementum, which is mainly a sort of a reshaping of the root surface. We also have curettage, which, however, is not aiming at doing anything to the root, but it's something that you do subgingivally to remove the pocket epithelium. However, nowadays, it's something that has not been used for such a long time that I wouldn't even comment. So we have 3 types of instrumentation, and we have 4 types of tools to achieve that. These are ultrasonic, curette, lasers, and air polishers. Bear in mind that at the European Federation of Periodontology, we recommend to use just the first 2, scaler and curette, because these are the ones that actually show the highest level of evidence. So when taking on board this instrument and these 3 types of instrumentation, it is clear that debridement can be done just by lasers and air polisher. Scaling is done by ultrasonic. So when I'm using ultrasound and I'm doing scaling, I'm in fact also doing debridement already. That's why the study that are showing lasers versus and ultrasonics plus versus ultrasonic usually don't show much difference, because in fact, when you're doing an effective scaling, you already passed the phase of the brightness. And this is also true for curette. When you're doing rep planning, actually you're also doing scaling in the brightness. But let me go a bit deeper in this and try to understand why we use mixed technique. You know, an ultrasonic works for vibration, for irrigation, and for cavitation, which is true in general, but very little relevant in perio treatment, because in perio treatment, subgingivally use very fine tip, which actually vibrate very little. Cavitation is nearly absent in thin tips. You need to have larger tip to show cavitation. And irrigation is usually blocked by the soft tissue wall of the pocket. And these translate clinically to the fact that when you are doing a subgingival instrumentation, you spend much more time than the time that you would normally do when actually when you're doing things supragingivally. So let me actually show a classical technique. You see here we have a 4 millimeters with some pulse discharging. You can see from the x-rays of these 1.5 that there is no calculus whatsoever. So in this case, we're just going to move the lateral point of the last 2 millimeters of the tip very gently from the coronal up to the bottom of the pockets and vice versa. And then you see the pocket closure 3 months after treatment. When it comes to curette, I mean, you know, there are plenty of curettes, but I mainly use just the 1, 2, the 11, 12, and the 13, 14. I just use mini micro. And I have to tell you, if I would have just used one curette, I think, thank God, we have the 13, 14. With the 13, 14, I can do all the entire dentition. I'm actually very happy to do it. So the problem with curette is that sometimes you might have noticed, first of all, I would see that when I teach, the majority of my students rely on fingers and wrist movements instead of working with the shoulder and forearms, which is very dangerous because, as you know, this just basically increases the scratch and doesn't allow you to be effective because you can't really control the movement. But most importantly, the main problem that we have when we're using manual instrumentation, that if your curette is well sharpened, at some stage you keep cutting and you keep removing things until you see the liver and the lung. You will keep cutting. So the issue is, how much should you use a curette? And I think it's very relevant, the fact that this very nice study from Kadosh teaches you that after 10 strokes of curette, you're just removing tooth and not any more substances deposited on the root surface. That's why the curette is just a finalization of the instrumentation, which is nowadays a blend of the two. You see here we have 8, 9 millimeters with bleeding on pockets in these areas. So we start mainly with ultrasonic instrumentation, and then we finalize with manual instrumentation, that in this case will be an horizontal curette movement on the canine and the central, which are baccally inclined towards us. And then we'll have a vertical instrumentation of the distal and the mesial of the lateral. But I'm not gonna, you are more familiar than me about this. And this is, of course, the pockets closed 3 months after treatment. So to finalize this bit, there are various types of root instrumentation. According to the type of instrumentation, an instrument should be chosen, whether you want to do debridement and so forth. And efficacy depends very much on the techniques that you're gonna choose. So when we actually did this consensus, I think we've highlighted the fact that non-surgical treatment, and please do let me actually acknowledge the work of Ginny Suban, who's been my first mentor for non-surgical instrumentation at the Eastman. When I was studying there in 2001 and I was a student, I was 12 and Ginny 18 back then. And we were, she was supporting in my M-Clean Dent in perio. And we started to work since ever. And Ginny was really my mentor. She's my mentor, of course, in instrumentation. And the work that we did with Ginny for this article was to try to understand the efficacy of periodontal treatment, non-surgical periodontal treatment. And it is very clear that the 75% of the pockets are closed with non-surgical instrumentation, which means 3/4 of periodontitis cases can be most probably managed just by non-surgically. And I think this is very much important because this is the base. Non-surgical instrumentation, subgingival instrumentation is the base of treatment. And there are no differences whether you're using hand or ultrasonic. In fact, if you see a pocket like this one, this is an 11 millimeters pocket. And what makes me laugh that when I started perio in 2000, my back then clinical mentor would have told me, if you find a pocket deeper than 8, advise the patient that you're gonna go for surgery. And you see, this is an 11 millimeters pocket. You see there is lots of edema. And this is the phase of ultrasonic scaling, then the finalizing with the manual root planning. And this is 3 months afterwards with the closure of the pockets. And you see no more swollen, which means that it's something that I would always suggest to all of you, never have a loser approach. You can find the pockets of 3 kilometers, you sit there and you devote yourself completely and you start to think, I'm gonna bloody close it. And that's the approach. Then it may happen that you don't succeed. Not bad at all. You can always rely on surgery, or in some session, even a second subgingival instrumentation, it might be needed in some specific occasion. But you never start by saying, I will not make it, this guy needs a surgery. No, you go and you put your curette down and do whatever you have to do. So no loser approach. Anyway, so subgingival instrumentation can be performed by hand or power instrument irrespectively. And what is important, there is no difference in terms of delivery of the treatment, whether it's given with quadrant or full mouth. Let me show you some cases. This is Bruno. Bruno was 60 something, was sent to me mainly by the wife because of halitosis. And you see a mix of everything now, pockets, plaque calculus, gingival inflammation, gingival hypertrophy, granulation tissue. There is plenty of things to do. So because Bruno is retired and she doesn't really have any issues of timing, nor she does need any antibiotics, I would rather actually see Bruno many times so that I can work on his supragingival plaque control. That's why I would have a conventional stage approach. And this is the image of the attachment loss. Bruno is actually a stage 3 generalized grade C periodontitis. And this is Bruno. And this is Bruno 3 months after a conventional non-surgical periodontal treatment. You can see now we have reduction of inflammation. Bruno can clean in between. He moved to a 5% of plaque, mainly because we worked on the interdental brushing. This is the highest critical point. And of course, in this case, also some electric brushing. And this is the lower jaw before and after. So we end up with just a 4 millimeter site with no bleeding. And in this case, we submit Bruno to periodontal supportive treatment. But in this case, which is very different, this is Valerio. Valerio is in his 30. You can see there is an important distraction in the lower central incisors. He has a kind of a severe case because he's a grade 3 generalized stage C periodontitis. Being so young, I want to also give antibiotics. So by choosing to give antibiotics, of course, I will not move for a stage approach, but I would try to actually do all the instrumentation within 24 hours. And so I decide for a full mouth approach. And this is actually Valerio before, and this is 3 months after treatment. And I think this is very clear. How do I choose one stage to be conventional in quadrant or sextant, or to be full mouth? Well, first of all, the issues, should I have to give antibiotics? If the answer is yes, you go full mouth. Logistic. As you can imagine, many people are flying from New York to be treated by myself in Pisa. So of course, when they come, I'm not gonna tell them to come weekly just to make a sextant. So even logistic, of course, has an impact. We are in real life, but also the medical status. And the reason is that a few years ago, we did publish this study where we showed that in the aftermath of the treatment, in the last 1 year, 1 day or so, there is a tremendous systemic inflammation when you do a proper periodontal treatment. But if you do it full mouth, the inflammation is triggered, whereas when you do it conventionally with just short session, the inflammation is not triggered. Now, this per se is not an issue for all the majority of the patients, but when you are doing instrumentation with subjects with cardiovascular comorbidities, I think it would be important to keep your session low and not to trigger a systemic inflammation. But the evidence that you can use both, and you just apply one or the other according to, of course, your clinical need. So subgingival instrumentation is the keystone of periodontal treatment. It is strongly recommended in each patient with periodontitis. It's actually mandatory. Ultrasonics and curettes are the instruments of choice. and full mouth and conventional approaches can be used according to the patient characteristics. So now that we set the ground, how do we apply this to treatment in terms of COVID? Well, the first question is something of you might have noticed during the first lockdown. At the end, it was very clear because during the first lockdown in Italy, I think in UK as well, yeah, we weren't really allowed to work but to provide emergency treatment. So we basically left all my patients, I run a center, just purely perio centers. We left all our patients without supportive treatment. And when they came back, I found tremendous relapses. It wasn't just 1-2 months of or delay, it was proper relapse of perio. So I wonder whether this condition of pandemic might have had an impact on oral health. Now, the pandemic per se has been defined as a sort of a warlike or even a sort of a major earthquake. So this is the way the pandemic has been perceived. So the question is, would actually the oral health change in some situation? Well, first of all, I actually would highlight the important work from the group from Professor Planchak from Zagreb and Professor Bozic that actually highlighted that subjects that are undergoing worse stress, in fact, do experience a worse periodontal status compared to the one that actually did not. And in also in terms of earthquake, to which I'm actually personally extremely attracted, there is this very interesting study showing that the subject that actually went to go through an earthquake and a tsunami in Japan showed actually higher chance to be affected by periodontitis afterwards. So social conditions, we know, have an impact. The reason being most probably associated with inflammation. In fact, the evidence is pretty clear. If you are lonely, if you are socially isolated, you tend to be more prone to inflammation, which is, we know, is the base of periodontal susceptibility. In fact, when we look at a condition like the one that I'm showing you now, and we wonder why on earth a patient like this is actually more likely to develop a myocardial infarction to the same guy that without periodontitis. Most probably this because his periodontitis can be looked like by quite a large area of ulcerated epithelium, most probably large as a cuff, and that creates bacteremia, but also because of systemic inflammation. So systemic inflammation is fundamental. And we know now that in COVID pandemic period, there might be a chance that there is a higher tendency of this. So our group tried to highlight it and we published on Journal of Dental Research, which were really the measure that we applied in Italy, because Italy, as you know, is infamously being the first country in Europe last year to be affected by the pandemic. So we kind of developed some strategies. In fact, the pandemic may act as a social catastrophe. During dire times, periodontal conditions degenerate, and the COVID-19 pandemic have determined empirically a worsening of the periodontal condition. I think this is very important. We need to keep all this in mind when thinking about our perio patients that are under supported treatment. How can we be close to them if we cannot provide our treatment? Now, as the European Federation of Periodontology, I'm actually the chairman of the European Projects Committee, which is in fact dealing with the project of communication. And one of the things that we immediately aligned was to try to make some infographics to support clinicians in how to set them up for the treatment. Now, patient triage is crucial, and I'm not going to go through all the questions of patient triage, but basically the relevant aspect of it is to try to highlight, as you know, whether there is a risk of a symptomatic phase of the disease. That's why to be effective in triage, you do it both telephonically when the patient needs. But I also would like to show you something important. Now, you see, this is me talking on a conference call with one of our patients that will come the day afterwards. Why this is important? I think this is crucial. With this condition, they will see a ghost with a hat, with glasses, gloves, and of course masks and so forth. They will not see a human. But periodontology, like I think medicine generally, is about human beings. You need to connect to your patients if you want to change your patient's habits. You need to understand the person. if you want to make sure that this patient is eating well, is brushing properly, and most probably would give up smoking. Basically, you need to create a human connection before a professional medical ones. In short, you cannot do perio if you don't love people. You need to be genuinely curious and interested in the other human being that is sitting next to you. And this is something that you will never do with a ghost dressed in white. The day before, we have a conference call or even a WhatsApp call where I show my face and I talk to them. I think this is very important. They need to see the humans on the other side. Then it's important to prepare both the patients and the clinician. And once again, I'm not going to go into the details, but what I would like to highlight is what I can see on social media. And I see these people working in dentistry as they would work actually in an intensive care unit affected by COVID, and nothing wrong with that. But I would like to ask, knowing the cost that we have in dressing and setting up our surgery when we do perio treatment, I would sincerely like to ask to these colleagues if they get changed 20 times during the day to see each single patient, because if they don't, what they're doing, they're just moving the deposits of virus on their clothing from one patient to the other. That's why instead of dressing up as ICU, I think it would be just important to make sure that proper hand hygiene is performed, and we are dressed like onions, of course, with different layers, and we can remove the outer layers among patients to make sure that we are not gonna inseminate, we're not gonna move the virus too much in case one of our patients might be actually affected. Bear in mind though, and I think this is crucial, that the preliminary report that we got both from China, from Italy, and now other countries are showing that dentists, and I would assume also hygienists, even before the outbreak was clear, even before that we were in a status of pandemic, that most probably were exposed a lot to the virus, didn't really show an incident that was higher to the general population. In fact, you would feel and you would look that there is an incident that is below the ones of the general population. I think this is very important because it's a reinforcement that we have been doing the right things for years. So wearing a mask, wearing gloves, and wearing protective high measures such as the goggles or masks whatsoever is most probably more than effective to deal with the virus. So I think now we need then to understand the periodontal treatment. How should we perform periodontal treatment nowadays? Well, of course, contamination is crucial. So I think measures to keep the aerosol down are important, but we cannot avoid doing it because we need to use instruments to be effective. And actually, we did publish an ebook that is free. If you want to download it, you just need to go on, connect to my Instagram account, and there is a link over there, and you can download it. But basically, there are various types of aerosols, and we have the splatter, of course, that is not even aerosol, it's above 10 micron, but below 10 micron, you have different type of aerosol, up to what is defined sub-micron aerosol, which is 0.51 microns. These are crucial aspects, the 1 to 3 microns, because if you compare those to, for example, a human hair, or even just a granule of beach sand, you'll see how small these particles are. And these particles are crucial, the one below 2.5 microns, because are the ones that most probably would carry the virus as well. And they would actually have different dynamics compared to the one of 10 microns, which are heavier and they go on the floor. So in order to measure what happens during periodontal treatment, we did perform a study with a gravitator, which is an instrument that actually does measure, in fact, the concentration of these particles. And we actually, what we did, we created an instrumental setting in which we were instrumenting with ultrasonic instrumentation in the upper buccal anterior area for 15 minutes. And then we measured up to 2 hours the dynamic of the aerosol. And you see, interesting enough, that the lower particle, like 0.3 micron, they kind of stay for other 15 minutes after a treatment. So they are kind of floating in a sort of a very interesting dynamics from a physical standpoint, which means that the fine aerosol is most probably a nebula that is moving around us even when we finish our treatment, which is most probably what I know now, that we've been living, breathing the nebula of our patients all our life, because we really are submerged by it, especially when we change the chair one patient after of the other very effectively. So it's interesting to see that the 1 micron aerosol get a peak, but the 5 micron and 10 micron don't peak, but they go down because they're heavy, so they go on the floor. So are the fine particles the one that shows the different characteristics? And I also did, let me now highlight just for 1 second, check please carefully the movement of using curette. You can see that the fingers and the wrist are still, and the movement is mainly done by the forearm and the shoulder. That increases effectiveness and control. So, but we also measure the aerosols. In fact, you do produce aerosol as well. I mean, there is a perturbation of the air even when we are using curette, although it's mainly done with 0.3 micron and very little. If you compare, you see in orange the ultrasonic and in gray the manual, you can see that the ultrasonic does produce much more aerosol. And then we also assess air polishing, because you can see that the air polishing, you can imagine that there is an important aerosol distribution. In fact, interesting enough, it gets higher 15 millimeters, 15 minutes after instrumentation, and it stays for other 15 minutes at least, which means that when you're using aerosol, you're really creating a sort of a nebula of very fine, when you're using air polisher, you're really creating a nebula of aerosol that may last for longer after treatment. So these were actually ultrasonic and curette. See the entity of actually the impact of aerosol, of air polishing. If you see the scale, you realize the amount of aerosol that is produced by applying air polishing. So the question is, how should I instrument nowadays? Well, to me, you should rely mainly on supragingival manual instrumentation. So I'm actually got the sickle back, and I have to say this is something that you see, I'm trying to show you these bits of calculus. This is something that I wasn't even taught in 2001, but now I started to use some manual instrumentation as well for the supragingival. Subgingivally, I use both curette and ultrasonic with high power suction, and I try to make short session as much as I can and use a lot of higher power suction. And we've been limiting for the last months a lot the air polisher. So to now pave the way of the conclusion, just to make sure that doffing and removal of the clothing is the critical moment. Remember that the literature showed that, for example, for the Ebola virus, healthcare providers do get infected when they undress, not when they're working. So the removal, especially of goggles and the masks, is the critical moment. Those are the moments where you need not to breathe and close your eyes and remove the mask far from your face. This is really the critical bit. Always remember that is the doffing, the critical moment. So to conclude, and I'm actually 5 minutes short, I was so concerned about the time that I've been a bit shorter. And basically, periodontitis is highly diffuse and will increase in the next few months. I have no hesitation in understanding that this social confinement, that the tremendous stress and fears that we are living, these extraordinary moments, will actually affect very much the susceptibility to periodontitis and even the effectiveness of the patients to take care about themselves. People eat less regularly, they smoke more in this period, so surely there is an impact overall on the possible effect that there might be. Treatment is articulate. Periodontal treatment is articulate, but is extremely successful. The majority of the patients that receive a correct treatment will actually keep their dentition in the long run. During this specific period, however, clinicians must compensate their physical absence through social presence. You know, I was creating video on YouTube that I was sending link to my patients on a weekly basis when I was at home. We try to stay close. And when I can, when I have special new patients, the day before I have a conference call because I want them to see my face. They need to talk with a human being, not to a ghost. And treatment should be relying on trying to limit aerosols by implementing possible alternatives and manual instrumentation. Of course, manual instrumentation is a challenge. Most of the people haven't really properly trained or taught how to use, for example, accurate subgingival effectively. But I think it's something that we need to rely the most, not just for our own sake, but for the sake of our teams and even the patients that would move around in and out our practice with their mouth open. And you know that now this is even more important because we have also the first evidence that is showing that periodontitis is also associated with a deterioration of the COVID status. Subjects with periodontitis, in fact, are 3.5 more likely to be in intensive care unit if affected by COVID compared to subjects without no periodontitis. So without any further ado, I would actually now thank you for your patience, and I'm looking forward to your questions later on in the panel.
Lovely. Thank you ever so much, Felipe. Thank you very much for that. Could we have Michaela and Julie, please? Could you put your cameras on for me?
Yep.
Okay. Michaela, is your
I
camera on?
so it falls to me now to introduce our next speaker. You can hear me okay, Sharon?
We can hear you, yeah.
Excellent, okay. Well, Julie shouldn't need an awful lot of introduction to most of you, but for those who don't know her, Julie Deverett qualified as a dental hygienist over 30 years ago, and she's the immediate past president of the British Society of Dental Hygiene and Therapy. Now, she's worked in many different settings and has had experience as a manager, a tutor, administrator, as well as a clinical dental hygienist. Her last clinical role was in a holistic dental clinic where she treated many patients who had diverse medical conditions, chemical sensitivities, and those that preferred a more natural approach to life. She assisted and featured in the latest Oral-B video on how to use the Oral-B test drive demonstration toothbrush, and is passionate about encouraging its use in practice. And I did not write that. Julie is fully aware of the challenges facing the profession and is keen to allay any fears many may have when working in the current climate, and how they can continue to deliver effective preventive advice to their patients. So over to you, Julie.
Wow. Can you see me? Yes. Can you see me now? Everybody, can you see me?
Yeah, we can see you.
Brilliant, thank you. Okay, so good evening, everybody. I'm following two fantastic speakers, and what I'm hoping to do within this presentation is kind of round it all off. Mike has talked about the surgery, the conditions. Filippo talked about the treatment of perio and a few other bits and pieces there. And I'm now going to look at how we can, as clinicians, make sure that we continue with our preventative advice that is so essential in this day and age. So what should you expect from me? Hopefully some reassurance and guidance on the safely delivered prevention advice in the clinical settings. Be familiar with the current guidance and standard of operation procedures when delivering oral health in education. In practice, recognise the reasons why oral health education is essential. Be reassured that hands-on demonstration can be used safely in a clinical environment, and then understand the infection prevention and control measures that are required when using oral health aids with patients. So where did it all start? Background, we all know last March it hit us like a brick. Lots of things were happening coming up in the middle of March, and we were all getting a little bit nervous. I know certainly I was. And then there was a national lockdown, first lockdown in March. UK is made up of 4 countries, and we all dealt with things in a slightly different way. I'm in England, living in England, and we ceased seeing any patients. The only people that were open with the UDCs. So they continued to see patients in some of the other countries on a emergency basis. Lots of restrictions were put in place on this. We had so much paperwork, admin, SOPs, but the main concern was the aerosol generated procedures. Now, Mike's already told us about this and spoken about this. And again, I can just reiterate, we've been dealing with AGPs for years. The problem was we had a new virus that we were having to deal with, and we didn't know how it would be transmitted within our environment. So that was one of the main concerns for us. Then our PPE, you know, gone are the days where we could just put on a fluid resistant surgical mask and pick up the ultrasonic, obviously goggles as well, ultrasonic. Now we've gone from that to having to wear respirators if we want to do any AGPs. So things have changed for us, and trying to adapt that, we have to look at different ways of how we approach our whole treatment planning. And one of the things I think that I was trying to encourage during last year was looking at how we do our prevention within the clinical environment. Now, SOPs, as you can see here, a whole vast array of them. The main one is the Public Health England one, the COVID-19 Infection Prevention and Control Dental Annex, Appendix. And all 4 countries have signed up to that, and they've taken that as their base. Some of the countries have added a little bit, changed that some elements to it, but essentially all the information comes from this document. And BSDHT also put out their own toolkit, because we were getting so many inquiries about what can I do, what can't I do, and there was conflicting advice because there was so much information out there. That we put together the Return to Work toolkit, which I think is absolutely fantastic. Now, these guidance, as Mike has said, are live, and the last update on the COVID-19 was in February the 3rd, I think it was. So they are constantly looking at it. It's a changing world that we're living in, and therefore we have to keep up to date with all the documents. So what I've done is kind of taken some of the relevant parts of those documents. Patients will fall into either low, medium or high risk COVID pathways. They must be screened or triaged. And I think Filippo dealt with this very, very nicely in some of the questions that were being asked and things that we have to ask. And I think Wales have actually expanded some of the questions that they ask their patients beforehand. Is there are different symptoms that are coming out now with COVID. Standard infection control precautions are required for patients in low risk pathway, even if an AGP is undertaken. So basically, and we've always done it, is you treat everybody as though there's something they're carrying some disease, whether it's COVID or another infectious transmittable disease. And again, this is what we've always done. So nothing's really changed in that. Practices should ensure physical distances and good hand and respiratory hygiene measures are followed at all times throughout the practice. And the reason I've put this in there is because there has been some transmissions between dental staff. And one of the things that they believe has been happening is that we're fantastic. In surgery, we're gowned up, we're respirators, a lot, cleaned. But as soon as we step out that surgery door, then things may not be quite as they should be. You should still be wearing a mask. You should still be doing social distancing, good hand hygiene. All those measures should still be in place outside of the surgery door. Okay, so please be aware of that. This one's from Wales, and I like this. They've actually mentioned oral health advice, and they do state it's not an AGP. Preventative and self-care measures delivered in line with delivering better oral health, and you hear a lot about delivering better oral health, is considered not an AGP. So it's something that they're encouraging. Right? You don't have to be gowned up or to the nth degree. You can deliver it safely. This one I put in again, it's just again to say about the disinfectants, make sure it's effective against viruses, bacteria and fungi. And again, this is from the Welsh SOP. No settle time is needed for most non-AGP procedures. what they were doing in Wales is, if there was a procedure that they felt that it wasn't an AGP, but sufficient splatter and droplets were being performed or exuded, then there should be a minimum of 10 minutes kind of downtime at the end of that, so that it allowed those droplets, as we've, the last two presenters have said, to allow them to settle, and then the cleaning. And I think this is very important, because there's some research that I'll be showing you, and hopefully those people in Wales will be confident that using some toothbrushes, you don't need to have any settle time for it. So why is oral hygiene important, advice important? Now, I'm talking to an audience here that has got such a wide strength in oral hygiene, and why we could spend a whole day talking about this. So I've picked up some points, hopefully you'll agree with me on them. Firstly, there's been a systematic review of the professional mechanical plaque removal for the prevention of periodontal diseases. And what that showed was that without oral health advice, there was little value in actually providing this. And a few years ago, there was that study that came out in Scotland saying that, the scale and polish, it does nothing. And a lot of people were up in arms about it. But to be honest, you're absolutely right. There's absolutely no point. And again, you all know this. There's absolutely no point in just getting a patient in, taking away, disrupting the bacteria, the biofilm, removing the calculus and sending them on the way, because that's not benefiting the patient. We know that without oral health advice, nothing's going to move forward. It also encourages the patient to take ownership of their own oral health. Again, we've all had it. We've all listened to patients coming in and said, "Oh, I should have seen you 6 months ago, and it's now been 10 months, and so my mouth is obviously going to be in an awful state." Well, no. If you can maintain good oral hygiene, you should be able to take yourself over those last few months. Yes, I know there's going to be exceptions to that, but again, it's making sure that the patient understands it's not us that does the work, it's them. One of my greatest sayings is, what I do helps, but what you do matters. And I think that's something that, I really, really made sure that my patients knew, is that it's not what I'm doing, it's what you do at home, the self-care, that really makes the difference with this. Obviously, prevention and maintenance of perio disease, prevention of caries, along with all the dietary advice. And then, as Filippo has already talked about, it contributes to general health as well. If you've got a lot of gingival inflammation, it can have an impact on your general health and systemic health. So there's some of the reasons why we need to be doing this and to continue to do this. So who should deliver this? A, dentist, dental hygienist, dental therapist, dental nurse, oral health educator, all of the above. Well, my answer is all of the above. It's a team approach. You can't work in an environment if there's only one person in that environment that's passing on this message. It has to be everybody adding their own little bit. And one or two things that I really, really I'm quite passionate about and really do like is these 2 points here: making every contact count and brief intervention. Now, the making every contact count, that's a government kind of initiative, and it's really to do with health. So obesity, smoking, well-being, exercise, dental health. Anybody in that medical environment has a patient in, just even with 30 seconds, they can pass on a message to that patient that might make them think a little bit more about their health, their oral hygiene, and it hopefully will then, they will start making those changes. And that's where brief intervention comes in. And that can be from 30 seconds to 5 minutes. It doesn't need a lot. It doesn't need a lot of time. Now, one of the examples I can think of is a patient comes in for an examination, goes to see the dentist, caries, and there's some perio or gingival inflammation. So the dentist at that point hasn't got a whole hour to be able to speak to that patient about the condition. But they have a short window of opportunity here to say to them, this is what's happened in your mouth. This is what you could do, and this is why it's happened. But it would be beneficial to you to go and speak to and have an appointment with, could be the dental hygienist, dental therapist, dental nurse, oral health educator, who will then give you further information that will enable you to make those changes that hopefully will prevent this happening in the future. So that brief intervention then can be spread to the rest of the team. But I think it's really, really important that we do that. When should the oral health advice be given? Now, my view is that if you, and the scenario I'm thinking of now is when that patient does come to you and it's their first appointment, it should be done after you've done the patient assessment. So your indices, bleeding and probing, plaque or disclose. And I am aware that there are many of you that don't have as much time as some of us. I was lucky I had an hour for my first appointments. And I know that there's still people working on 20 minutes, which, you know, I think is shocking in this day and age. However, bleeding on probing and plaque indices really do help. It allows you to go back, once you've done all of this, it allows you to go back and review and to see how that patient has done. Without that, how do you really know? And it also allows you to tailor it to your patient's needs. And one thing I loved about Filippo, it said about the human connection. I like that. I like that because that's one of the things that I always did. Yes, I love to know about my patient, but I was also doing it for a reason. You know, where did they work? How do they work? Have they got children? You know, are they sleeping at night? Because all those things will then influence on the advice that I would speak to or discuss with that patient. You know, I live in the south of England. A lot of my patients before COVID was travelling into London every morning and night. So they'd be up early, home late, working all day, sitting at their desk and looking at their oral hygiene. I couldn't say to them, yes, first thing in the morning, you must get up and brush for, you know, 2-3 minutes. It just wasn't going to happen. So you discuss this with the patient and you work out the best way in which, or they do, work out the best way in which they can approach these things. And what, you know, and again, don't set them up for failure. If you know that they're not going to be able to, I don't know, incidental clean every day because of this, then you allow them to do it, or you allow to say to them, all right, then if you can't do it every day, then maybe at least 2-3 times a week, gets them started. So it's tailoring the needs to that individual. Biofilm disruption, and again, Filippo used it, subgingival decontamination. I'm learning just as much, I think, as everybody else on you tonight, but biofilm disruption, that's the priority. We've already said, without oral health advice and disrupting that biofilm, no amount of work that I'm going to do is going to make any difference. So by putting that at the beginning of the appointment, makes it more important, and it shows that it emphasizes that point. It's not about, you know, scaling all this stuff off and then in the last 5 minutes, oh, this is how you get rid, you know, and this is how you prevent it from happening again. No, let's start with this. Put that at the beginning of your appointment. And then with the, you know, again, Filippo's talked about it, the European Federation Periodontology with the S3 level clinical practical guidance, practice guidance, and the BSP have looked at this, and also I'll show you this. The first step, the very first step, support and motivate. Removal of supragingival plaque. Now, that doesn't say that you have to do that with instrumentation. That could be with a toothbrush and calculus. Then therapy, and within that therapy, interventions to support oral hygiene. So in the very first step, that's what you do, oral hygiene. And then the bottom, once you've done the therapy, it should be reevaluated regularly. So how should we deliver this? And again, within this COVID era, this is where it might have to look at it slightly different. It's a skill. Now, trying to teach anybody, you know, tying your shoelaces, buttoning up a shirt, it's a skill, and it's something you need to demonstrate. And the delivering better oral health also states this. So if I can bring this over, and you can see here, decide on manual or power toothbrush, demonstrate, assess plaque removable abilities, and then set a target for next time. And then the same with interdental care. Decide on appropriate dental kit, demonstrate, assess plaque removal, and then set targets. So demonstrating is definitely the way that we need to be doing this. And I don't mean on a model. You cannot do this on a model. I mean, there are different ways of approaching this. When I've been taught a method of instruction course, and it was EDIP, explain, demonstrate, imitate, and I'm checking my time, and practice. There's tell, show, do. So there's lots of different ways to do it, but I like this one because it really does break it down quite nicely. So plan ahead. You know that that patient's coming in, and you need to kind of plan that session out. Assess the needs of the patient. You've done that by doing your assessment with the indices. Then demonstrate the process. And as you're demonstrating it, talk your way through it. Obviously, they've got a mirror. Then observe the patient doing it. So you now hand it over to them and allow them to do it. So you can then give them feedback on whether they're doing it effectively or not. And I never use the word correct. I always say effectively, because sometimes their method might not be the way I would do it, but actually it's working quite nicely. So effectively, I think is quite a nice, and it's a positive word rather than correct. I think correct or not correct is harsh. Then encourage the patient to self-assess. They will look at that and say, well, how do you feel about that? Does that feel good? Is that better? And talk your way through that. Then allow them to practice. Now, the way in which they do that obviously is not going to be in your dental chair, it's at home. So they go away. I used to bring them back, certainly about a month. I used to give them quite a bit of time to really adapt the method at home to get them used to it. And some people that were going from manual toothbrush to an electric toothbrush, they needed time to adjust on that as well. And then, as I said, you then review and prepare to modify the method. So again, when they come back again, you've got those indices that you've already checked, so you can go back to them and say, oh, you know, you were at 55% bleeding last time, you're now at 25%, fantastic. So they can see that things are moving in the right direction, which is fantastic. Great way to do it. What else do you need to consider for doing this? We've talked about AGPs and your PPE. If you are having a patient that comes in and you are doing AGPs at the moment, what you may want to consider is your PPE, because trying to communicate with the respirator on is almost impossible. So if we're going to do this at the beginning of your session, what you could do is have your surgical mask on rather than your respirator. So you've got your surgical mask and your visor, and obviously your apron and all that. So by doing that, you can communicate much, much better than having a respirator on. And then once you've done that, you can then, and obviously prepare the surgery. So you can, and again, this is something that you're going to have to decide yourself. You can either have the test drive out on the side with an array of interdental aids, or you can have them in a cupboard. And what I would hope is if it's in the cupboard, you're not doing AGPs, so it's safe being in the cupboard and for you opening the drawers, is that once you've done your assessment, you could then speak to your dental nurse and say, yeah, I'll need this interdental aid and this toothbrushing technique, toothbrush. So you need to really think ahead a little bit more. And then once you've done that and you are then going to go on to doing your AGPs, yes, you would need to kind of deglove and pop the respirator on and that. But at the beginning of the session, there's no reason why you shouldn't really have your surgical mask on instead. Interdental aids. Now these are actually an array of brushes that I've got in my cupboard upstairs. So hopefully I've got most makes, I think, in there. When you're teaching dental cleaning, again, it is so important that you show them, they demonstrate, and then you give feedback. And it's such a skill. I always say this, you know, when people come and they can't use the floss, and it is a real skill, and you need such dexterity to be using it. So, you know, it's something that you have to persevere with. Follow the demonstration stages that I've gone through, and then disposal. If you're using bottle brushes, then I used to clean them, put them into a pack, and give it to the patient. They like a bit of a freebie. Otherwise, it goes in the bin. All right. Gone are the days where people used to use them, clean them, and then put them in the autoclave for the next patient. And yes, I never did. I have to say, I never did, but I do know of people that did. So toothbrushing, again, same thing happens here. If they've brought their own brush, fantastic, because you get to see what it looks like. What I used to do, if they had a manual toothbrush, I had these disposable ones, the Cavex ones, and they were fantastic. They were in their own cellophane, really quite a nice small brush. But I would also show them and demonstrate with the Oral-B test drive. Now, one of the questions that's come up, is it aerosol or splatter? And what has happened is that because we needed to know whether it was safe to use these in the clinical environment, some studies have, or there has been a study of which Mike and Filippo were part of, and I'm going to show you some of the results now. So what they were looking at, they wanted to look at the liquid droplets, the size of the liquid droplets. Mike has talked about aerosol size and droplet size, and they did it in 3 ways. The Malvern Spray Tech, which was a laser particle size measurement device, Dust Track, which is an aerosol measurement device, and then high-speed visualization. So this is the Malvern Spray Tech. You can see the toothbrush there, and then but what they found with this is that the droplet sizes for both brushes, it was the Genius and the IO, they were on average around 500 microns. So quite large droplets that were being produced in that. So no aerosols whatsoever, but yes, splatter. The Dust Track, same again. You can see the Dust Track there, and then the aerosols, and they used glycerine, water, toothbrush slurry. And what they found with the Dust Track, again, that virtually no emitted particles were observed with the test liquids during the test. Right, so there was virtually nothing happening at that point. And then the visualization, I love this. Right, so you can see this is where the slurry was coming in, and all these are the droplets coming out. So you can see it coming. But to be honest, you know, it's unlikely that we would have this much liquid. Yeah, this isn't particularly pleasant, but it's unlikely we would have this much liquid anyway. But you can see the droplets coming out, which is a great visualization. And what they found with this, and this goes back to one of Mike's slides, is that it was splatter that was seen. 99% of it were larger than 0.3 millimeters, and it dropped within 1.8 seconds. And this is what I like as well, is that as they dropped within a meter. That's 95 centimeters. So when you do get these droplets, they will land within a meter. So if you are sitting at the end of the chair, they're not even going to reach you. So the conclusions from it then was that the IO and the Oral-B Genius test drive emitted droplets that you could categorize as splatter and not aerosols. All right, so that's for you, Laura. You could, if you wanted to, use a high volume suction, but you don't really need to. Making sure that if you've got your PPE on, you've got your mask, you've got your visor, and you're sitting away, there's not a problem. Now, I'm going to show you a video now of how to use the test drive. But when you've got your patient in, one of the things you've got to make sure, and this is absolutely essential, is that when you give that to the patient to demonstrate with, you must be very clear that they must turn it off before they take it out of their mouth, because otherwise we all share in that experience. And, you know, they can spit into a cup or spittoon, depending on what guidance you're using at the moment. And please remember that this video was filmed pre-COVID. Okay, so and one of the points I really want, one of the reasons why I wanted to show you that is when you use the electric toothbrush, it goes flat on the surface, not at 45-degree angles. I've heard and seen it so many times, and it really shouldn't be used in that way. It should be flat on the surface so that the head can rotate into the gingival margin. Now, once we've used it, we then need to clean and disinfect it. And the one good thing about the Oral-B test drive, it has been microbiologically validated. So they have looked at it, and there is a way of cleaning it. This is the IO. They've used microZid AFs. You wipe down the surface, then you fold it out for 30 seconds, fold it over and clean it in a twisting motion. Then you immerse it in a bath for 15 minutes, or if you've got an ultrasonic, put it into a bag with some solution, and then for 5 minutes. Then you take it out, tap it 3 times and leave it to dry, and then package it up and sheath it again so it's ready to start for the next one. And if you have the Genius, again, make sure you're taking it from the base, you're taking it all the way down over the toothbrush head and discarding the whole lot. Same again, you're wiping with the wipes for 60 seconds, then 30 seconds, and then the tip for 15. Then you clean down sprayed with detergent, wipe it down again, 30 seconds, immerse in a bath of disinfectant for 5 minutes, air dry, and then set up ready for the next session. How easy can that be? All right, so that will then validate the disinfectant process for it. So it is safe to use the Oral-B test drive within practice. So from me, that's the end of my presentation. So hopefully I have reassured you and given you some guidance on delivering prevention in the clinical setting, and that you're familiar with it now. You know the reasons why oral health education is essential and important, that you're reassured that hands-on demonstration can be used effectively, and the infection prevention control measures that can be used. These are the links to the SOPs, but they should all be on the BSDHT COVID-19 website part. And from me, thank you.
Thank you, Julie.
There you go.
Thank you, Julie. If you just turn off your mic and your camera, and it gives me great pleasure to introduce Michaela O'Neill. It's weird because I've got my current boss and my two ex-bosses on this webinar. So this is Michaela. Michaela trained as a dental hygienist and is a past president of the BSDHT and is currently the vice president of the International Federation of Dental Hygienists. She works for P&G as a senior professional and scientific relationships manager. Hello, Michaela.
Hello, Sharon. It's not the first time we've spoken today or this week, has it?
Shall we ask Mike and Filippo and Julie to put their cameras back on?
Please, yes.
Yeah.
Let's get the panel ready. And I've got some questions. There have been loads of them. Thank you all.
No, I've been watching them.
Well, the more questions that have come through, I think it's probably better for time if maybe I don't ask them all verbatim, but we look at the themes that have come through and we'll ask certain things. Now, I shall start off, I think, with some of the very early ones here when Mike was talking. And there were a lot of questions, Mike, about the filters that are being used. Can they be used in a room, a surgery without a window? Can they, do they have to have the filters changed monthly? Because you mentioned that they were monthly. And yeah, is there any particular one that you actually recommend more than the others?
Yeah, you mean the filters on the FFP3 masks?
Oh, maybe that. Hold on.
I think.
Sorry. Yes.
I think those are just according to the manufacturer instructions and the usage that they're being used within the school, because we've issued them obviously to all the students as well as the staff. So you just go by what the manufacturer tells us, and the recommendation made for our usage was they should be changed at the monthly. If you were asking about the air cleaning systems, yeah, they can be used with the windows closed. They can be used with the windows open, which is preferable. But if you don't have windows and don't have windows to open, then they can still be used. They'll still do the air changes per hour and take out any aerosolized COVID virus.
Brilliant. And do you all panel have one of these filters in your practice or in your surgery?
Yeah, we've had one, again, because it was a holistic dental practice, we've had one for years. So it was quite easy to just continue with that and then increase some of the other aspects of infection control. But we've had one for years.
Yeah, I think the important thing to realize is the vast majority of dealing with the problem is in all the recommendations with the masks, etc. But having one of these the air cleaning or air scrubbers in the equation as well just picks up that last little bit. You've got to do all the other stuff first, and this is an additional bit that will just I mean, it reassures me when I hear them going on, etc., and they're ticking away in the background.
That's great. Good.
I think, sorry, can I just come in? I know that SDCEPT are looking at this because the biggest issue is ventilation rather than, air filters. I think it's the ventilation and it's getting that part right. So I think that's where the focus is going to be kind of pushed.
Okay. This is a particular one as well. How long does it take for hand gel to deactivate the virus?
Well, the surface of the virus, it can be deactivated. It's a matter of seconds. If all you're doing is disrupting the glycoprotein envelope on the virus. So depending on whether it's soap, alcohol, or any of the other chemicals, it's a matter of seconds. You're not in there for sort of a few minutes. They work on the surface. They impact on the surface very quickly. Great.
Filippo, this is one for you. It's not a nice one. It looks like a difficult one as far as I'm concerned, but let's see what you think.
If I manage.
This person would like to know what your thoughts are on the recent studies showing a correlation between periodontal disease and increased COVID-19 mortality. Is this something he would recommend discussing with patients?
Well, of course they should. They should indeed. I mean, we last week we had an Instagram live, in fact, with the European Federation of Perio, specifically on this study. Bear in mind, it is an association study, which means that people that die more of COVID are more likely to have more cases of periodontitis, which doesn't mean that periodontitis caused the death in COVID. There is no causality here. It's not an intervention trial, it's just an association study. So it might be that there is an inflammatory tendency that would appear both as a very severe case of pneumonia as much as periodontitis. It doesn't have to be one causing the other. It can be just a shared things. But what is also important, and one has to realize that if one with periodontitis, if a subject with periodontitis is going to get intubated, is going to have a higher chance to develop pneumonia anyhow. And this is, we know from historical literature. So the point is that taking care of the gums at the moment might be fundamental, because in case you might have to be intubated or go in intensive care unit, the presence of tremendous amount of dental plaque and dental mass in your dentition may actually increase your chance to have some kind of lung infection. So I think this is of utmost importance. It's something that the patients should know. However, it has to be communicated gently and kindly. It's not that you're going to say you better treat your gum disease, because in case you get COVID, it might be a problem if you get intubated. But I believe that it just stresses the importance of the oral health within the place of the overall systemic well-being.
Yeah, can I actually just come in there, Michaela, because that was the impact of the oral hygiene status on your survival from ventilator-associated pneumonia was the work that we did in the critical care unit, in fact, in Cardiff over the last 5 years. And as Filippo rightly says, your chance of, if you go on a ventilator, your chance of dying is directly related to the oral hygiene, because the bacterial species within the oral flora or the oral microbiome will predispose to the infection within the lung in relation to ventilator-associated pneumonia. So.
It just reminds me of one SOP that I read at the beginning of COVID that actually advised against brushing teeth with an electric toothbrush in patients that were on a respirator because of the risk, or the supposed risk of actually spreading COVID. Anyway, so that turns it on its head, thank goodness. Another question then for the panel here. What's your opinion on the use of ultraviolet light to destroy viruses, either in the aerosol or on surfaces? Do we have one?
Well, in the air cleaning systems, you've got one of these air cleaning systems have UVC in there, yeah. But that's a definite.
Mm-hmm. And does it work on surfaces as well? That's what was being asked here about using UV light on surfaces.
I have no experience, but we don't use UV light on surfaces.
Okay. I certainly know, again, from sitting on the SDSEP workshop group, that Kath Noakes has spoken about this, and the two systems that she can say that there is evidence for, one is UV light and the HEPA filters. So both can be limiting. It depends on where it's sited, but the only two things that she would, I'm loath to say recommend, but to say that there is some evidence to suggest that they work, is HEPA filter and UV.
Okay, great. Thank you, Julie. Is there any data regarding COVID death among dental staff?
Well, within the UK, I mean, sadly, there's the very sad case in April of the 51-year-old dental nurse in Swansea who died of COVID. Other than that, I'm unaware of any other cases directly related to dental staff in the UK. Filippo may have different information for Italy.
Surely not in UK. I don't have the UK data. I can tell you that we ran actually a survey still within the EFP, and we get the majority of the data from UK, Italy, and Spain, as far as I remember. These are mainly data from the British Society of Perio, Italian Society of Perio, and Spanish Society of Perio, but we're just analyzing the data now. But all the reports in literature worldwide are just reporting the fact that, unfortunately, some of our colleagues do die. We don't know whether this was actually, however, taken during the professional settings, but the incidence overall is actually not higher than the general population. In fact, it's lower. something that I was trying to highlight before.
Excellent. I have another question for you, Filippo, from Juliet Reeves. Hello, Juliet. It says, did the aerosol data presented in association with air polishing include the use of high volume intraoral suction and or high volume extraoral suction, please?
Not at all. This is the first study in which we just wanted to highlight the dynamics of the aerosol, what produces and how much. Of course, we actually ran other 2 studies, which is, for example, to see whether instrumenting the posterior part of the mouth has an impact, and it has. So that means that when you're doing ultrasonics in a lower second molar, it's going to be completely different than doing it in a central, of course, because the cheeks per se do provide a sort of a shell. And then we finally ran the last study, which is with high power suction and also with air purification systems. But I have to confess, sadly, that we haven't analyzed the data yet, so I don't like to comment on things that I don't know the data. Once again, these data are proof of principle to understand what is producing more in terms of aerosol. I think the thing that we need to bring back home is to think a bit higher than the COVID. And I'm sorry, now the focus is on COVID, but please look at the big picture. The issue is not just infection. The issue is that we live in a poor quality air system throughout all our working life. So the issue of purifying air and trying to be sensible to this is a duty that we have towards us, irrespective of the virus. It's just in terms of really of contamination per se, which doesn't have to be infective. It can be just even pollution per se. So I think these are just practices, and I think that will be the highest inheritance that the COVID, hoping that it will leave us soon, that this inheritance will leave to us, to focus on the quality of the air we work.
That leads me on quite nicely to something I've been thinking about a lot. Previously, when we have had any kind of virus to deal with, like HIV and all the rest, we have had new procedures implemented, and we've never gone back to what we did before. So I suppose the big question on everybody's lips here is, do we see us ever going back to how we were before COVID? Now, given as well, Filippo, that your studies have shown that dentistry was not at risk, and in fact we're at less risk of catching COVID than during the procedure because of our procedures, will we go back to what we did before?
$1 million question, isn't it?
Yeah, it is. I just love to know your opinion.
Yeah, my opinion is not that I'd be right though, because I thought back in March that we'd all be up and running again in September. So I might have this completely wrong, but I do believe that we will start to work with the virus as we have done with all the others, and I hope that we will get to a point where respirators and gowns are no longer needed. So it's more of a hope than a prediction.
Michael, do you have any thoughts on this?
I mean, I can remember in the 1980s when sort of mid-late 80s when HIV appeared. I was working in Scotland at that time with a lot of patients who were HIV positive, and we got dressed up like, spacemen and things that we're doing now. And of course, now we're hoping by the year 2030 that there will be no HIV within the world. We will have been controlled. So, I mean, I think you hope that we will go back to something that's less cumbersome than having to work with these respirators, which for some people, I mean, it's impossible. So I would hope that as the understanding improves and vaccination gets out there, the virus within the population will change, and we may just treat it like other flu viruses. Sadly, though, there will be some more viruses coming down the line, I'm afraid.
There'll always be something. What about you, Filippo? Do you have any thoughts on that?
I think we will go back to where we were with just some precautions that we get. Like I think we will all use FP2. We'll not use anymore just a simple surgical mask, some things like that. But I relied a little evidence on we had after the first outbreak, last summer. I remember that when numbers were extremely low, people were acted like the pandemic never really existed. And I think this is part of, biologically, humans is made to forget about pain. Otherwise, people will just stop at the first child after the first delivery, and most probably we would actually do many other things in a more protective way, but we are made to remember the good things. And in fact, I'm actually looking forward to the post-pandemic moment, because it's actually after the war that the most nicest things are built. So I'm very excited about it. I mean, just looking forward to see what will happen afterwards. Of course, there will be some inheritance and I hope air quality and a higher protection. But I believe that we will go back to hugging and kissing each other, which I know, I've been living in England, might not be such a tremendous issue for you, but in my country it's fundamental. We are
Too right,
sincerely
too
looking
right.
forward.
I have a question here as well, Mike. Somebody had mentioned in your lecture, you've mentioned stannous, and they wanted to know stannous fluoride toothpaste, and they wanted to know, were you going to expand on that at all? Was there anything else about?
Right. It's not specifically stannous fluoride toothpaste. It's toothpaste with a number of ingredients. And it goes back to the fact that a number of substances will disrupt the viral envelope. Stannous, the other ingredients in other toothpaste and ingredients in other mouthwashes all do impact on the transmission of the virus, because it disrupts that surface coating, so it can't then subsequently invade the lung cells. So yeah, it's not particularly stannous, but stannous is good. But all the ingredients of all
brilliant, Mike, isn't it?
Well, it happens to be yes.
I know, I'm joking.
It was research actually done by another company, which I won't mention tonight. But it's the good thing about it. And very early on, you know, I did a thing on ITV live on the 6 o'clock news, and I got some stick for it, but I got a lot of thanks for it. But in that one, I did say, look, two important things is wash your hands, but brush your teeth. And we had that as a strap line on my email signature for a while, because it just makes good sense that 2 minutes twice a day is good. One, because it will be disrupting the envelope of the virus inside your mouth, albeit we don't quite know how long for at the moment. But also, if you then actually did end up on a respirator, if you had good oral hygiene, you were less likely to die.
Well, that's a good selling point.
Brush your teeth. Wash your hands and brush your teeth.
Yeah, exactly. We're getting a couple of questions in around the use of the test drive and being a meter away. And there's a bit of confusion about, somebody said, did they understand correctly? Is it safe for the patient to demonstrate their technique with the electric toothbrush as long as you remain a meter away? Should you not do the demonstration in patient's mouth? So could we just have a wee bit of clarification around that, please?
Yeah. Yeah. Okay. So what I was, yes, you can. I mean, there's no other way of doing it. You've got to be up close and personal with them. But remember, you've got your visor on, you've got your mask on. So if there is splatter, which we've shown on the video, that yes, there will be. I'm not sure that you would have as much splatter as that, because the amount of liquid that was being poured on there did exaggerate it, I think. And having used it, I mean, I didn't stop using the test drive. I constantly used the test drive throughout the whole of this period with not an issue. My main concern was saying to the patient, make sure you turn it off before it comes out, because we all know, you know, it goes everywhere then. But yes, you have to show it in the patient's mouth. And not once did I have anything on my visor, not once. But when the patient is using it, there is that chance that they will take it out without turning it off. So being a little bit further away just helps with the protection. But again, you've got your visor on. It's really not going to be an issue. You know, I am such an advocate of using test drive or anything in the mouth. Years ago, we used to do it on a model. How on earth a patient learns how to brush their teeth or do anything like that on a model is just beyond me. They have to feel it. They have to know what it's like. You have to see them. And no matter what they say, you know, they'll tell you that they do it in that way. And then they go to show you and it's completely different. So it is vital that it is used to demonstrate. And it's the same with, you know, manual toothbrushes, if that's what they want to be using. You have to show it in the dental chair. There is no other way of really getting this skill across to a patient.
Well, another question came up about the fact, why is it that you put on an electric toothbrush at a 90-degree angle, but you have to use a manual toothbrush at 45 degrees. Are you okay to answer that one, Julie, or do you want me to?
Again, I think what I mean, you'll probably have a better answer for me, but basically that video, and I do apologize, Sharon did tell me that I had to put sound on, and I didn't put the sound on, so I do apologize, but you can access that video on YouTube and on the BSDHT website, so it is on there, so you can access that anyway. But basically the head, it's round head, and as you're placing it, it splays slightly, so you do have that, there is a word for it and it begins with S and I can't remember it at the moment, but as it's rotating and oscillating, it
shear
will
forces. Shearing forces?
Shearing forces, that's the one, thank you. You'll get that working around. If you go at a 45-degree angle, you then start losing that. So it has to be placed at that on the tooth surface. And if you heard the video, Faye is saying, you know, the tooth surface is rounded, so it needs to cap or wrap around that tooth surface. So if you start putting it at a 45-degree angle, it's not going to work. The manual toothbrush is designed in a different way. So they are designed to work at a 45-degree angle. Although if you are using a toothbrush, a manual toothbrush that has bristles that are all different lengths, you try doing that at 45-degree angles and that doesn't work. That's one that's designed for anybody to pick up and just scrub their teeth. So, but the Oral-B test drive and the Oral-B electric toothbrush should not be used at 45 degrees.
Great, thank you. I've got a couple of questions around the amount of time should be left in between non-AGP appointments. Is there a time? Does anybody want to, Filippo, do you want that, or Mike?
Can you say it again? I'm sorry.
Oh, so, were you not listening to me? How many times? They're asking about how much time should one leave between non-AGP appointments. Is there any follow time or downtime?
What the non-AGP is? I'm sorry, I'm bad in these acronym things.
Oh, non-aerosol generating procedures. So I'm assuming that they mean if you're just using hand scalers or OHI.
Okay, no, well, the recommendation was 15 minutes with proper ventilation among patients. And on the base of the preliminary data that I showed you, it is sensible that there might be some minute before all the particles would actually go down on the floor. Then of course we need to use all our disinfectant and so forth. So with ventilation, you know, it can be open air windows during summer, of course, in the climates that are allowing to, or just, you know, proper just air ventilation, a good one. But 15 minutes, I think it's actually a good time point.
Yeah, I mean, in our open clinics with the air ventilation system, we've got the main ventilation system, air conditioning system, and the air cleaners. For say in an oral medicine clinic, I don't generate any AGPs. We're doing procedures generating aerosols. Our patients come in and come out as normal, but just with the usual. Well, we haven't got the usual patient throughput at the moment, because what's limiting it is that we don't have enough waiting area to socially distance the patients in the waiting room. But coming into the surgery, there's no specific, a clock starts and we have to wait 10 minutes. By the time the patients have gone, units have been cleaned down, etc., we just carry on as normal.
Can I come in on this one, Michaela? Because I don't think this question is being asked because they want to know about non-AGPs. I think correct me if I'm wrong, whoever's asked the question, but what we're finding is that a lot of practices are expecting their dental hygienist, therapist to go back to doing 30 minutes back to back.
Okay.
Hand scaling. Now, in my world, that would not happen, because if you are hand scaling, you need more time. So therefore, I would suggest that if you can, that you need extra time so that you are then dedicating your scaling time. Obviously, your oral hygiene first, then your scaling time, and then you've got time to write up your notes, you've got time for the dental nurse to then decontaminate and clean the surgery. So mine went from, I was using airflow and I had 30-minute airflow, so I then went to 45 minutes hand scaling. So that gave me time then, plenty of time to have with the patient, deliver the treatment, and then to clean down the surgery after. So there wasn't fallow time, but there was extended time to allow for better treatment.
That's brilliant. That will probably make an awful lot of people feel an awful lot more confident about asking for extra time. That's great.
That's the yeah. That is it.
I'm going to ask one last question, and I think then we'll wrap it up. I think we've the talks have been excellent tonight. But one question that has come up is, how safe would it be to treat somebody who has had a positive COVID-19 test? How long would you need to leave it after that before you could actually treat them?
Well, I suspect it would be between the recommended isolation time you would do at the moment, depending on where you are in the world. I actually haven't thought of that. If patients are symptomatic and have raised temperature, etc., obviously they're treated as still being positive. See what Filippo says, but I would have thought if the 2 weeks or so have gone by since they were tested positive, they've been asymptomatic and they've done their isolation period of time, then their time is served and just carry on and treat them. Yeah.
Well, we of course, each country has its own regulation, and first of all, you need to follow regulation of your General Dental Council. I mean, so I don't know anything about UK. I can tell you that in Italy, of course, after 2 weeks, after 10 days, you will be tested again if you're asymptomatic, and if your test is negative, then if the patient needs to be treated, of course, you will be treated. Bear in mind that if somebody has COVID positive and needs treatment, treatment will be provided anyhow, of course, with any possible attention. And the rest is that if the patient doesn't get positive, he will be kept tested up to 3 weeks. Now, if at 3 weeks you are asymptomatic and yet positive, you are considered healed anyway.
Okay, that's great. Well, look, all it leaves me to do really is I have a couple of things I want to say before I wrap up here. Let me just get my screen shared with you. No, she said, I'll share my screen first. I think I hadn't done this before.
Evidently, I've put a lot of people off Scotch eggs. I quite like
that. I think you have actually, yeah. There we go. Can you see my screen?
No, we can see you.
Yep. Just a few things that I want to say before we go. One, I want to show this QR code.
I'm sorry,
because
Michaela can't see your screen. Do you want me to do it?
I'll do this one instead. There's 3 different screens here. There we go. We're on.
Yeah.
Yep.
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 Okay, that's grand. Well, all I really wanted to say here was that I've got a QR code on the screen for those of you who have asked questions about the disinfection of test drive and about using the test drive and getting refills. There have been a lot of questions on that tonight. If you scan this QR code, it'll take you to a form to request some contact from your TM. Now, it will be a virtual contact, obviously, at the moment, because they're not out because of the restrictions, but they should be able to help you with anything you need and speak to you virtually. And below that actually is a link. And if you want either the link or the QR code after today, you should be able to get that from Sharon. Also, some people have been asking Filippo for the link to the book that you mentioned. And I'm hoping then as well, you might be able to give that link to your Instagram to Sharon as well, so people could then find the book there. And the last thing I'd like you to do
is post on Instagram, but if it is not, I will gonna add it.
Perfect. That'd be perfect. Thanks. Oral-B have just started in the UK a professional only site, a dental professional site for test drive users. And I'd really love for you, if you could, to sign up and follow us, because we will be sending and posting lots of information on disinfection, how to use it, that kind of stuff, and the things that you might need. So if you could follow us in that, that would be brilliant. And it just leaves me to thank this fantastic panel who've been absolutely brilliant. It's been a marvellous evening. Thank you so much, Mike, Professor Michael Lewis, Professor Filippo Graziani, and Julie Deverick. And I also want to thank Sharon and all the staff at BSDHT and all of BSDHT for helping with Oral-B and helping us all to help promote oral health in our nation and do the best we can for our patients. So thanks very much to all of you. And I'll just pass over then, Sharon, to Diane.
Yeah, Diane, can you put your camera and your sound on? There we go. Yep, you're okay.
Okay, so I just wanted to say thank you so much to everybody. Michaela, I think you just did all what Sharon had messaged me about, so that's great, thank you. So I just wanted to say as well from everyone at BSDHT, thank you to all the panelists, to everybody, to Michaela, to Oral B for hosting this tonight, and to Sharon and all her work as well. She's been frantically going around in the background today as well, so thank you so much. It was a really interesting evening. It was really fun, and some really good discussion as well at the end. So thank you, and some fantastic questions. And there's some really good comments on the chat as well. So well done, everybody. It was really great. Have a good evening. Oh, Sharon, do you need me to tell you about the certificates?
Yeah, just to say that I'll send out the link for the feedback over the next couple of days, and I'll also convert this webinar to a movie, so I'll send you a link to that. I'll include the test drive video that Julie was showing, and if Filippo can send me details of his Instagram, I'll include that, as well as the QR code, Michaela, that Michaela showed at the end of the session. Okay.
Thanks very much.
Take care.
Thank you, everybody.
Night, and thank you, everyone. Bye-bye.